Bahia. That is the main public health lab for the state of Bahia, integrating clinical expertise for the diagnosis of emergent diseases. So thank you very much, Antonio, and the podium is yours.
Thank you very much for being here to discuss Flaviviral hepatitis acquired in endemic destinations, Flavivirus distribution and ecology, and hepatotropism are very interesting. And a part of that has been explained by the speaker that preceded me here. And Flavivirus, they are a very complex group of many different viruses with ecological niches, with different amplifying hosts, birds and mosquitoes from Culex species for Japanese and West Nile virus, primates, humans and non-humans, and mosquitoes from Aedes genus for dengue, zika, and yellow fever, and rodents and ticks for tick flavivirus infections. So flavivirus are very widely distributed in the whole world, and right now dengue is one of the most important of one of those diseases. And hepatic involvement differs very much among those flavivirus, being Japanese and West Nile mainly responsible for central nervous systems invasion and encephalitis. Zika virus, as we're going to see, involves very rarely and very moderately the liver. And dengue and yellow fever are, I would say, the main prototypes of liver involvement, with yellow fever being one of the most devastating infections for the liver and may lead to a high severe disease with a high mortality rate. So right now, if you think about a return traveler, right now, most cases of dengue fever right now are expected in that time of the year, from February to June for the Americas, and especially for the period from June, July, up to October for Asia. And here are the numbers we've seen in 2023 for Asia. So more than 3,000 cases, reported cases in Bangladesh, more than 140,000 cases in Thailand, more than 170,000 cases for the Philippines. But right now, we're experiencing a huge outbreak in Brazil. So Brazil right now is one of the leading countries with reported dengue cases, with more than 3.5 million reported cases up to now. So we haven't finished our dengue season, and we probably will end it with more than 4 million cases. But South America is very heavily impacted with dengue also, with Argentina 250,000 cases, Mexico 52,000 cases. So for a return traveler with fever, you've got to suspect of dengue. For Zika, right now we have come in a quiet situation in the world. We don't have any outbreak right now, but we do have Zika circulation still in South and Central America, parts of Africa, and Southeast Asia. And yellow fever also, it's right now more concentrated in Africa, especially in the Democratic Republic of Congo, South Sudan, Cameroon, Congo, Chad, Niger, and Nigeria. So those are the important countries you should look upon if we're looking for those diseases. So starting with Zika virus, Zika causes a kind of soft dengue-like infection, and we have published 4 years ago a study involving 663 patients with an acute viral syndrome screened for Zika with RT-PCR. Those patients they were coming to the emergency room and were screened for many other diseases, including Zika, and part of a protocol for Zika detection. So 78 patients were positive at that time, representing a prevalence of 11.8% of the cases, and only 2 patients had elevated AST levels, and almost the same for ALT2, above 100 units per liter. So that means a 3.2% increase in liver enzymes, very different from a dengue patient. So it's, and also, when you look at platelet counts, Zika patients with thrombocytopenia of less than 100,000 per cubic millimeter was present in just 1.3% of those cases. So Zika, most patients presented with myalgia, reported fever, headache, and a pruritic rash, okay? And we see here that kind of rash. It's very pinpoint rash. It many times involves the palms. And in the beginning of the Zika epidemic, a lot of patients were screened for syphilis because of that involvement in the palms. And here we see a patient co-infected. He had RT-PCR for Zika and chikungunya at the same time. And those ulcers, oral ulcers, are much more frequent with chikungunya. However, never say no in medicine. And it has a recent report from China of a 29-year-old Chinese returned from Cambodia that experienced high fever, chills, fatigue, sore throat, and myalgia. And that case, although it made an eventful recovery, you can see that had pretty much elevated liver enzymes as we expect for Zika. So at day 7 of symptoms onset, it reaches the highest point of 511 AST and 283 ALT. So moving to dengue and the expected course of the disease, after an infected mosquito bite over here, we expect generally a 5-day incubation period. And around 24 to 48 hours before symptom onset, we expect the start of the viremia and NS1 antigen detection, okay? It's interesting in dengue because dengue virus affects very much the microvascular network, increasing permeability. So at the point that we start symptoms onset, we start microvascular increasing progressively its permeability, and the risk of severe dengue, it's where you expect a decrease in viremia, but you are at the highest point of vascular permeability. So that occurs around day 3 to day 5 after symptoms onset. And that's exactly the period that patient, is clearing its fever, but it's at the highest risk for severe dengue. And that's the same point that the risk for severe hepatic involvement occurs also from day 4 to day 8, as we're going to see. So dengue hepatitis, it's kind of very, very frequent, and it even helps for the diagnosis of a fever in a return traveler from South America, for example, at that time of the year. Souza and colleagues in Rio de Janeiro in 2004 studied more than 1,500 dengue patients and found elevations in ALT or AST in 65.2% of patients. So it's it's often frequently detected elevations of liver enzymes. However, just 3.8% of those patients had aminotransferases higher than 10 times the upper limits of normal. So what we expect from the dengue hepatitis classical case, we expect AST levels much higher and generally higher than ALT. Bilirubins are generally normal in dengue fever. However, they may be quite high when you have a severe dengue, especially with liver involvement. And histological liver changes reported in dengue include microvesicular steatosis, hepatocellular necrosis, Kupffer cell hyperplasia, Councilman-Rocha Lima bodies, and cellular infiltrates at the portal tract, because dengue virus is able to replicate in both hepatocytes and Kupffer cells. So, moving to what would be a clinical profile and predictors of a severe dengue hepatic involvement. Last year, there was a study involving more than 1,800 patient dengue cases admitted to the University of Sains Malaysia Hospital, Malaysia, from 2016 to 2019, and 7.2% of those patients required ICU admission, with an 11.4 mortality rate among those 114 dengue severe cases. So dengue severe cases represented 6.2% among those 1,500 patients. The median duration from onset of symptoms to ICU admission was very short, showing what I said initially, because after you have the D4 and the D5 of symptoms of certain dengue patients, you may really expect a very high evolution for those patients that go for a severe case. And the most frequent reasons for ICU admission were shock in 69.3%, third space loss with respiratory distress in 50.9%, severe liver impairment in 32.5%, and severe bleeding in 30%. And what's interesting here, that's among non-survivors, 69.2% had fulminant hepatitis. And it's interesting that median ALT and median AST also on ICU admission really had a they are very different from those that survived from those that did not survive. So median ALT was 529 for non-survivors versus 72 for survivors, and median AST was 838 for non-survivors versus 144 for survivors. And it's also, that study showed that peak AST or ALT after ICU admission was much higher for ICU non-survivors. So in this retrospective study, going further on in dengue, severe hepatitis and its and predictors for death. It's a retrospective study of more than 2,300 hospitalized dengue patients screened in Thailand between 2007 and 2019. 151 patients, or 6.5%, very similar to those statistics we have seen in the other study published in Singapore last year, had what they call a DISH, a dengue-induced severe hepatitis. And that was defined as an AST or ALT higher than 10 times the upper normal. From those 151, 17 patients progressed to acute liver failure with hepatic encephalopathy and an INR greater than 1.5. And MELD score, that is a score for hepatic transplantation that takes into consideration bilirubins, creatinine, and INR, and MELD score equals to or higher than 15 predicted acute liver failure from those DISH patients, okay, with a high sensitivity and specificity. And the risk of death from DISH was really related and highly related to the development of acute liver failure. 58.8% of those dengue patients that progressed to acute liver failure died versus 0.8% of those DISH non-ALF patients. However, they could not predict ALF death, patients that progressed to acute liver failure that died by dengue severity, extra hepatic complications or liver-specific treatments, maybe because the sample was not so high. So a mild AST or ALT elevations for up to 5 times the upper limits, it's expected in dengue fever. It's related to the viral infection of hepatocytes and Kupffer cells. Higher AST-ALT elevations between 5 to 10 times the upper limits. You should watch out for warning signs in dengue, okay? And if present, this patient really needs hospital admission. And the highest AST and ALT elevations of more than 10 times the upper limits, or a single ALT or AST higher than 1,000 units per liter, really predicts severe dengue. It's because of a direct viral injury and also because of a relative ischemia in the dengue shock syndrome, high mortality rate, ICU admission, the need for fresh frozen plasma and blood transfusions, and ultimately to liver transplantation. So what are the warning signs in dengue? So lethargy or restlessness, abdominal pain, continuous abdominal pain with tenderness, persistent vomiting, a liver enlargement of more than 2 centimeters in a patient that did not have a liver enlargement previously, mucosal bleeding, clinical fluid accumulation seen as ascites or a pleural effusion, or a hematocrit rise concurrent with a rapid fall in platelets. Those are the warning signs. Okay? So treatment is supportive, it's vigorous, hydration, 10 to 20 ml, classic crystalloid solutions per kilo per hour. And fresh frozen plasma, it's important in those severe cases. This has been shown in a randomized clinical trial in Sri Lanka with 180 patients studied with platelets between 10 to 40,000 that the use of fresh frozen plasma had an impact of slowing down the thrombocytopenia. So it may be really helpful in severe patients. In blood transfusions, we should really, for severe cases, we should not wait too much for blood transfusions, packed cells, or whole blood, especially in drop-in hematocrit, or even if you have stable hematocrit but with clinical deterioration with metabolic acidosis. You should not wait too much. You should really go for it. And or with severe liver involvement with metabolic acidosis also. So the last resort for acute liver failure in dengue is liver transplantation. And Galante and colleagues here in 2019 described a 49-year-old woman from Canada that presented with fever, diarrhea, vomiting, following a trip of 2 weeks to Jamaica. And the initial workup showed very high liver enzymes. So that's really it's very concerning when you see a picture of that in dengue. Very high levels, the AST of 20,000 with coagulopathy, thrombocytopenia, metabolic acidosis, as I described earlier, accompanied by jaundice and low-grade hepatic encephalopathy. Dengue fever was diagnosed by positive real-time PCR, and within a few hours of admission, the patient had a dramatic worsening of the hepatic encephalopathy. And that's really the case when you see a severe dengue patient. It doesn't take too long for really complications sum up, leading to the need for intubation, use of vasopressor drugs with accompanying acute kidney injury leading to the need for hemodialysis, and the patient underwent liver transplantation for a neurological disease donor and made it quite well. So this is the liver histopathology in the extent of that patient, showing reasonably preserved zone 1 here, and a really severe hemorrhagic necrosis of hepatic zones 2 and 3 with relative preservation of zone 1 periportal zone. Okay? So finally, moving to the most dramatic, I would say, virus involving the liver for the Flaviviridae family. Yellow fever may present with varied clinical manifestations from asymptomatic or oligosymptomatic infection to a devastating course of the disease. Approximately 15 to 60% of individuals infected with yellow fever develop symptoms of the disease. Patients present with sudden fever, chills, headache, low back pain, myalgia. So maybe we may think that the patient, it's a dengue patient. Jaundice, you don't expect jaundice in a dengue patient, no, for classic dengue fever. And generally very high levels of AST and ALT, almost indistinguishable from a classic viral hepatitis. Excuse me. Most cases of yellow fever improve within 3 to 4 days. And however, around 15% develop a more severe form of the disease with high fever, jaundice, hemorrhagic diathesis, renal failure, cardiovascular instability, liver failure, it's very often frequent, with a mortality rate around 20 to 50%. And the kind of similar picture of liver involvement we may see in yellow fever, but it's much more dramatic because it's much more extensive, with lytic necrosis, calcium bodies, microvesicular steatosis, cellular infiltrate, and especially more pronounced in mid-zonal areas. So Brazil had a very important outbreak of yellow fever, sylvatic yellow fever. Brazil does not have urban yellow fever. We have sylvatic yellow fever in areas of, especially in the southeast part of Brazil, but also in the north parts in the Amazon area too. So in 2017, we had a huge outbreak of yellow fever, sylvatic yellow fever, with more than 800 cases, with a case fatality rate of 33.5%, involving mainly the states of Minas Gerais, São Paulo, Rio de Janeiro, and Espírito Santo. And in 2018, the outbreak was even more pronounced, with more than 1,000 cases of yellow fever and a 31.5% case fatality rate, involving the same states of Minas Gerais, São Paulo, Rio de Janeiro, and Espírito Santo. So at that time, Dr. Hu and her colleagues in the University of São Paulo studied the yellow fever hepatitis in those patients. And 79 patients were admitted to the ICU in that period from January 10th of 2018 to March 11, 2018. And most of those patients had an inclusion criteria for ICU admission as an ALT or ALT higher than 3,000, and INR greater than 1.5, platelets lower than 90,000. Most of those patients had acute renal failure, had hemorrhages or encephalopathy, and or hemodynamic instability. And all patients tested were positive for RT-PCR for yellow fever. So what's interesting is that the in-hospital mortality rate was really high. So a severe yellow fever hepatitis carries very high risk of death, okay? So in-hospital mortality rate was 67%, but also 84% of those patients had acute renal failure. 58% and that was really unusual because series before we didn't have that much pancreatic involvement as seen in this outbreak. 58% had pancreatitis, and 66% of those patients had heavy hemorrhages. So liver transplantation for yellow fever cases. So due to the significant number of yellow fever cases in São Paulo in 2018, liver transplants were performed in critically ill patients with acute liver failure. Alice Song and her colleagues present the first case reported in the world of a previously healthy 27-year-old woman who underwent liver transplantation for yellow fever-induced acute liver failure. The patient had 3 days of fever, headache, and myalgia. Initial workup revealed a leukopenia, thrombocytopenia, and very high levels of liver enzymes. And here also, the same as dengue, we expect AST in levels much higher or generally higher than ALT. Okay? The following day, a generalized seizure led to intubation and renal failure led to hemodialysis. Hemodynamic parameters deteriorated, requiring vasopressor drugs such as noradrenaline and vasopressin. And the patient was transplanted on the 10th day of symptoms and was discharged on the 41st post-operative day. And here we have the images of the liver explant of this patient and the liver transplant for this patient, showing a very different picture for yellow fever involvement. And finally, Duarte Neto and his colleagues at the University of São Paulo also, at that time, and based on 99 severe cases of yellow fever admitted to the Hospital das Clínicas of the University of São Paulo from December 2017 to April 2018, where they performed 7 orthotopic liver transplantations for those critical ill yellow fever patients. 57 mortality rate occurred after those liver transplantations. So 4 patients died, 3 patients survived. This is, as I said, this is the last resort we can do for kind of this critical ill patient with yellow fever, severe yellow fever hepatitis. So all those patients, all those 4 patients were submitted to autopsy. And all were men aged from 18 to 40 years old who had not been previously vaccinated against yellow fever. The time between onset of symptoms and hospitalization ranged from 4 to 9 days, and the time from onset of symptoms and the orthotopic liver transplantation ranged from 6 to 11 days. So it's a very rapid evolution in those patients. All those patients used sofosbuvir 400 milligrams per day on a compassionate basis. And all patients presented with fever, jaundice, myalgia, headache, abdominal pain, gastrointestinal bleeding, hepatic encephalopathy, and shock. So those are very severe patients with yellow fever. So what they found in those orthotopic liver transplantations, they found hepatitis with steatosis and mid-zonal apoptotic bodies in all those liver transplants of those deceased patients. Yellow fever antigens were present in 3 out of 4 livers. In yellow fever, RT-PCR was also found in 4 of those orthotopic liver transplants, although with a low viral load. So concluding, Flavivirus comprise an important group of arbovirus with hepatic involvement. Yellow fever is the prototype of infection with severe hepatic involvement, which can lead to acute liver failure and a high mortality rate. Dengue infection usually presents with moderate elevations of liver enzymes, what we usually call a transaminitis, but as we have seen, may run a more severe course, including acute liver failure. And Zika infection generally follows a very benign course with little hepatic involvement. And I also want to thank once again ESCCMID Global, want to thank my dear friend Alfonso and my fantastic wife is right here, watching me in this room right now. Thank you very much.
Thank you very much, Dr. Bandeira, for this excellent talk. So now we